chronic rejection begins at least 3 months after transplantation, and diagnosis is usually by biopsy showing graft artery or arterial proliferation, interstitial cellular infiltration or fibrosis, tubular atrophy, or glomerular changes. The number one risk factor for chronic rejection is a previous episode of acute rejection, and there's no real effective treatment, so prevention is paramount. Chronic graft rejection on ultrasound will have a thin cortex with mild hydronephrosis on both grayscale ultrasound and radionuclide images. Less specific findings on ultrasound include increased transplant echogenicity and reduced intrarenal vessel numbers. These signs have less prognostic importance, and generally speaking, ultrasound has little role in diagnosing chronic rejection. Cyclosporine has the greatest nephrotoxic potential of possible drugs and is due to vasoconstrictive effect on the afferent glomerular arterioles. Ultrasound is of little help because nephrotoxicity has a variable effect on Doppler waveforms, and it doesn't produce a visible effect, but it can occasionally reduce diastolic flow. Acute toxicity resembles mild acute rejection on radionuclide images because it causes decreased effective renal blood flow and parenchymal retention, while chronic toxicity can resemble chronic rejection with decreased renal blood flow with no parenchymal retention. And you can correlate the findings on ultrasound with cyclosporine levels and the clinical presentation of the patient as well in labs. And it can typically respond to reducing the dose. A failed renal allograft is often left in situ, and it's usually pretty small with fatty replacement, hydronephrosis, infarcts, hemorrhage, or punctate dense calcifications. On CT, the failed renal allograft should be differentiated from a pelvic tumor or contrast-filled bowel, which can resemble either of those. Ultrasound can be used for a couple different diagnostic tests in interrogating the renal transplant, and it includes ultrasound-guided biopsy or renal perfusion imaging by harmonic ultrasound. Ultrasound-guided biopsy is generally safe, but possible complications include perirenal hemorrhage, AV malformations, pseudoaneurysms, collecting system lacerations, and these typically occur less than 5% of the time. Risk can be reduced by using real-time ultrasound to guide the biopsy and avoid severing vessels or the collecting system along the way. And color Doppler ultrasound can ID intra and extrarenal vessels in an effort to avoid them. Ultrasound allows biopsy specimen to include multiple glomeruli also for better diagnostic yield. Vascular complications are seen in less than 10% of transplant patients, but they're associated with a higher morbidity and mortality than other causes of graft dysfunction. Angiography is the standard for diagnosis, but ultrasound with duplex or color Doppler is a non-invasive approach that can give you a clue as to the etiology of whatever's going on with the patient. And MRI and MRA have a superior contrast resolution, multiplanar capability, a lack of operator dependence, and no need for IV contrast compared with CT or ultrasound. Transplant artery stenosis is usually a late complication, and it's seen in about 10% of the transplant patients. Its symptoms include severe refractory hypertension or hypertension with an audible bruit over the graft or unexplained graft dysfunction signaled by an increased insidious rise in creatinine. Up to 65% of transplant recipients will have non-renal vascular hypertension in the setting of stenosis, however. Stenosis is usually at the anastomosis or proximal donor artery and is due to intimal hyperplasia. It's dependent on surgical technique, and end-to-end anastomoses have 3 times higher risk of stenosis than end-to-side anastomosis. And radionuclide images resemble those of chronic rejection. Also, giving ACE inhibitors stimulates renovascular hypertension with reduced perfusion. Doppler ultrasound criteria for major stenosis includes velocity greater than 2 meters per second, focal frequency shift greater than 7.5 kilohertz, a velocity grade between the stenotic and pre-stenotic segments of greater than 2 to 1, and marked distal turbulence appearing as spectral broadening. All of these criteria are seen in the left-hand side of the slide. You can see the plateau in the spectral image on the bottom that shows the velocities, so you can see the high velocity flow through the stenotic segment. So treatment and a definitive diagnosis is with a MRA or a CT angiography, and Surgical correction of the graft renal artery stenosis is usually successful, but the open procedure has complications. But if you do a percutaneous transluminal angioplasty with or without stent, it can improve blood pressure and creatinine with low morbidity and relatively modest cost. There's decreased hypertension typically within 1 day, but 20% may require repeated dilatation for maximum success. Thrombosis of the renal artery is pretty rare. It occurs less than 1% of the time, but it can lead to an infarction, and it's usually due to antibody screening, and it's decreased incidence nowadays because of antibody screening before transplant. Nowadays if infarction occurs, it's due to technical problems at an anastomotic site, and occurs in the early post-op period and usually leads to graft loss. Findings include severe rejection, severe tubular necrosis, and faulty surgical anastomosis. Symptoms can be include absent urine output with swelling and tenderness over the graft, inflammation within the transplanted kidney, may incite an inflammatory response in the adjacent visceral peritoneum with local pain resulting. Segmental infarct on ultrasound appears as a hypoechoic mass that is either poorly marginated or with a well-defined echogenic wall. A global infarction will appear hypoechoic and diffusely enlarged. Renal artery thrombosis can be diagnosed on ultrasound using duplex or color Doppler, and it appears as a absence of intrarenal venous and arterial flow, and it can be differentiated from severe rejection using angiography or magnetic resonance angiography. Percutaneous angiographic thrombolytic techniques, as early as possible, can save the graft from infarctions or thrombosis. More common than not, the graft will be lost if in the event of renal artery thrombosis, and then when that happens, you have to do a transplant nephrectomy. Arteriovenous fistulas and pseudoaneurysms can often be seen after percutaneous graft biopsy. Arteriovenous fistulas are due to simultaneous laceration of a renal artery and vein branch on biopsy, which then form a high flow fistula. It can present with gross hematuria of 5 to 7% of the time. It's usually self-limiting, and most spontaneously thrombose on their own, but it can be massive and persistent bleeding. And on color or duplex Doppler ultrasound, you can easily see arteriovenous fistulas as an abnormal high-velocity turbulent flow in a single segmental or interlobular artery and a paired vein, producing aliasing on color Doppler images. The feeding artery shows high-velocity, low-resistance waveform, while the draining vein shows arterialization. Pseudoaneurysms will appear as simple or complex renal cysts on grayscale ultrasound and localized areas of disorganized color extending outside the confines of the normal vessel on color Doppler. Treatment of AV fistulas and pseudoaneurysms is conservative because they usually spontaneously resolve. If the pseudoaneurysm enlarges or is greater than 2 centimeters in diameter, perform a selective transvascular catheterization, and if the AV fistula has hemodynamically significant AV shunting or hematuria, then embolize. That's only necessary in 1 to 2% of cases. Renal vein thrombosis is a relatively rare cause of transplant dysfunction, occurring less than 5% of the time. It's usually within the first week, but is a surgical emergency. Symptoms include immediate postoperative oliguria or anuria, graft tenderness, and swelling. It's usually due to extrinsic compression of the graft or kinking due to excessively long vein or excessive graft mobility. There's a higher incidence in the left lower quadrant allografts due to compression of the left common iliac vein between the sacrum and the left common iliac artery, which is called the silent iliac artery compression syndrome. Renal vein thrombosis appears as an enlarged kidney on grayscale ultrasound with reduced or absent venous flow on Doppler ultrasound and with possible reverse diastolic flow. Diagnosis will require MR venography, but a suggestive Doppler ultrasound is enough to prompt open surgery if possible. If that's not possible, then thrombolysis can be attempted, and this can sometimes salvage the allograft.